think we won't need that full amount of time for the regulation review. So if we get done with this a little bit early, I'm going to go right into the third section because I think we're going to need a little bit more time there, okay? So just to kind of give you a heads up, but I promise I won't forget your break. We'll still break even if we're partway into something, okay? So regulation review, this is the portion that I think we could go a little bit quicker on. There haven't been too many changes here. So we're going to start with sort of those bigger principal regulations that are put out by Medicare. We've got several. We've got the Social Security Act, the Code of Federal Regulations, which you will hear people refer to as the CFR. Then we have the Medicare Benefit and Claims Processing Policy Manuals, National Coverage Determinations, and then remember, outside of Medicare, their Medicare Administrative Contractors can also write policy, and that's where we get into the Local Coverage Determination. Now, what I didn't go into this and that you also have to remember is that you have your State Practice Act, okay, that you're also held to. So sometimes you really have to look at both the federal and the state regulations, and you're always going to follow whatever's the most stringent. And we'll see that in here as we talk a little bit about Medicare Part B and a 10th visit versus in Mississippi, we know you have a 6th visit requirement, right? So a couple things that are always a little bit different and that we also have to pay attention to the state. So let's start talking about Medicare Part B, because again, Medicare doesn't want to make things too easy for you, so they actually have, it's very siloed as far as Part B writes their own set of regulations, you've got home health writing their own, skilled nursing facility writing their own, but when we really dig into therapy, where there's the most detail is truly under the Part B side of things. There are several conditions of coverage and payment that have to be met in order for outpatient therapy services to be covered. First of all, the services are required because the individual actually needs therapy services. That seems like common sense, right? We're not going to provide therapy if they don't. There has to be a plan for furnishing the services that's been established by the physician or non-physician practitioner or by the therapist who's providing the services. And that plan has to periodically be reviewed by the physician or non-physician practitioner, okay? And the services have to be furnished while the individual is actually under the care of a physician. So we have to make sure that there is a physician that's available that's going to say, yes, this is a patient, I'm aware of this patient, I take care of this patient, and that's going to be really important because the next condition is that we actually have to have a certification of our plan. And that certification is when the physician or NPP actually sign off on that plan of care. So we sort of alluded to this earlier when I talked about technical denials, that this is a significant regulation that we need to make sure that we're following. Then what we also know is that our claims submitted for outpatient therapy, they have to contain the NPI for the physician who did the certification, so whoever's signing it and the NPI that we put on the claim have to match. And then we know we're also still doing, I think we're into probably starting year 3, I think, of the functional reporting or what everybody likes to call the G codes. That's something that has to be on the claim, otherwise your claim will reject. And those functional limitations that we report really should be consistent with what we're finding in the documentation. So let's talk about under the care of a physician. How do we really prove that? Well, technically, orders for therapy are not required by Medicare, okay? But they do say that having that order is prudent and can really help to show that the physician is involved in the care and that they're available to certify the plan. Now, knowing that a lot of you are in more of a facility-based setting where either you're in the swing bed units, you're in a SNF, somewhere where state survey may come in, and you may have other survey processes, these orders really are something that you want to have in place because that's something a surveyor is going to look for. So we always recommend that you have your valid treat order, clarification orders once you establish your plan that are going to tell on the order that what's your frequency, your duration, intensity, planned interventions, and if you make any changes related to that, to make sure that you're doing a new clarification, and then your discharge order. This can be very helpful in the event that we're having trouble getting a plan of care signed. It's helpful to have that order to back us up. So let's talk about what has to be in the plan of care for Part B, okay? As I said, the plan of care has to be in writing, and so this is actually in the benefit policy manual, and I don't think that everybody's always aware of it. But that plan of care has to be written or dictated, and what's really important that, yes, you're going to be able to start treatment, but it's who can start treatment before it's written or dictated. So if for some reason there's a delay in getting that plan written down or getting it dictated, the only person that can treat that patient is the evaluating clinician, okay? So I can't hand off to another clinician unless I'm going to be there to completely supervise the treatment, okay? Because I did the eval. So I really shouldn't be handing that patient off until I've got it in writing or I've got it in some type of dictated format, which that really makes sense, right? They need to know what the plan of care is so that they know what direction they're going. But this is something that I'll see once in a while when I do audits where I'm like, your plan wasn't written yet and you did 3 visits by another clinician. How did they know what to work on? Contents of the plan of care. What you want to remember here is that Medicare talks about the evaluation and plan of care actually as being 2 separate documents. That gets a little confusing for people because typically in most medical record systems it's one, because we just put that certification statement at the bottom or on our eval somewhere. But truly the contents of the plan of care are just your diagnosis, your long-term treatment goals, and then really what your plan is for therapy as far as the type of therapy, amount, duration, and the frequency of the therapy services. Now it does say that that plan has to be consistent with what your evaluation findings are, but those 3 bullets are really truly what makes up the actual plan of care that has to be certified by the physician. So let's go over a little bit of how Medicare defines those elements. Long-term goals. These should be developed for the entire episode of care in your setting. So really when you're thinking about it, that is where you want that person to be when you're going to discharge them. And it may happen that you don't always hit it, maybe the patient plateaus, that's okay, but we shouldn't see you writing long-term goals that you're gonna have to upgrade later, okay? These really should be at where you want the person to be when you're going to discharge, all right? Type of therapy is very simple. It's pretty, it's pretty self-explanatory. It's gonna either be PT, OT, or speech, and your eval is gonna show that information. The amount can be in times, the number of times per day, and that's really assumed that it's 1 time per day unless you specify something differently. Frequency is the number of times per week or the number of visits that you're going to see that person. And then the duration can be overall, I'm going to see this person over the next 6 weeks, or you may even write it in treatment sessions if it's something that works out a little bit better. Let's talk about what you can do to change the plan of care and what that means when you do it. Medicare defines out what is a significant change to the plan and what is not a significant change. And this is very important because if we make a significant change, we actually need to get that plan certified again, okay? And this is something I find that a lot of therapists don't fully understand it, and it's just a really important piece of things. So if I change my long-term goals on a patient, okay, I actually need to get that plan of care certified again. So let's say, for example, you had a patient that at the initial eval, it was not clinically appropriate to evaluate gait, okay? Maybe it was a weight-bearing status issue or the patient just wasn't doing well, gait just could not be evaluated. So my initial plan didn't have gait goals because I hadn't evaluated it to establish a baseline. When it comes time for me to get gait onto that plan, I need to actually do that and have that plan of care sent off to the physician to sign off on it because it's a significant change to my plan, okay? Things that you can change that don't require a physician approval on the plan, frequency, okay? So if, let's say I started this person out at 5 times a week, I'm pulling them back down to 3 times a week, I don't need to get physician approval to do that, okay? That's my clinical decision making. I do caution people if you go the other direction though, say I started at 3 and I'm gonna go up to 5, you really want to get that plan of care signed when you go in that direction because now I just added visits to my plan and my initial certification probably is not going to have enough visits covered, okay? So the way that they really look at that first plan of care and certification, let's say I was going to see somebody 3 times a week for 4 weeks, I technically have a certification that's going to cover me for 12 visits. So if all of a sudden I increase my frequency, I've got to monitor when I'm done with those 12 visits because I have to do a recertification then. So that's why I always tell people, if you're going the direction of maybe having to increase the number of times per week, just go ahead and get that recertified right away just so you're safe there. For duration as well, if it's just that maybe a patient missed a few visits, so you're extending out a week, but you still haven't gone over your total visit number, you're okay. If you've met the full visit number though, and you truly want to extend, then it would be a recertification. If it's something that's a procedure change, maybe I decide I want to add a modality or I hadn't put therapeutic procedure on the plan, I don't have to get that recertified. I do recommend, again, if you're in a setting where you are having state surveyors, that type of situation come in, make sure you write an order for that change because they're going to look for that. But as far as having to have the physician sign off on that, that's not something that's considered a significant change to your plan. So then I want to pop up to that bullet that says short-term goals. If I'm changing my short-term goals a little bit, I'm upgrading those goals, that's not going to be a change to my plan that requires a physician signature. However, what I don't want to ever see somebody do is, well, I didn't have a gate goal on my first plan of care, but I'm just going to stick it up here in the short-term goals because the technical regulation says it's only a long-term goal change. Well, it really is, it is a plan of care change. Just because you wrote it in the short-term goals doesn't really make it, make it right. So you would want to still get that signed off on. And technically, when you read the Medicare documentation, it's only long-term goals that are a requirement. So they don't even really mention the short-term goals. So certification, that again is that requirement that the physician has to sign off on the plan. So not only do they have to sign it, but they have to date it. Okay, now Medicare is nice because a lot of times the physicians forget to date things, that if we would get one back in return to us and that date is missing, they allow us to put a received on date and we can just write on there received on and put the date there. So they'll allow us to fill that in. But you want to make sure that somebody is taking a look at that and that somebody is making sure if that needs to be done that it happens, because something as simple as a missing date on a physician's signature can be a technical denial. We had one recently that they said that the date was illegible. Okay, we've had illegible physician signatures that we've had to go back and do attestations on. So I don't know quite how we're ever going to get physicians to sign better and make them legible, but they can get that picky on it if they want to. The certification really needs to be timely. And what they mean by that is Medicare actually has this in the benefit policy manual. It says as soon as possible. But then they go on to define that to say they really want that certification signature on your plan within 30 days of the start of care date. Okay? If for some reason you're having trouble getting those signed, and let's be realistic, we know that there are some physicians that you really have to hound to get these signatures, okay? I know when I used to manage an outpatient clinic, we had a physician that referred a ton of patients to us, but he was horrible about getting the signed documentation back from him. So it would, every once in a while the stack would start to get bigger, and I myself as the manager would have to literally go to him when I knew he was up in the pain clinic and say, I really need you to sign these today, and sit with him until he got everything signed and dated that we needed. But really trying to hit that 30-day time frame. If you're having a difficult time with it, they will allow delayed certifications, but you want to show that you had due diligence in trying to get that signed. So if you can keep record of the amount of times that you've faxed it, if you've made phone calls, if you can just keep a nice running log of all of those attempts to get those items signed, that's really helpful, that if you are beyond that 30 days, you can send that information with in case that ever would get requested to show that, you were making every attempt to get that signed timely. And again, that's sometimes nice where we've got those orders on top of things to sort of marry it all together to show that. All right. Now, your initial certification, remember, if some of you remember, years ago we had to do these every 30 days. Okay, everybody remember those days? Every 30 days we had to do recertifications. Well, then they made it nice and they switched to 90 calendar days, but what you have to pay attention to is that if you're doing a good job in really individualizing your plan, so let's say I do my evaluation today and I say, I'm planning on seeing this person for 6 weeks. My certification is only good for 6 weeks, okay? It's not the 90 days, it's the 6 weeks. So if I reach that 6 weeks and I want to continue to see my patient, then I need to recertify. Okay? Some people think, oh no, it's just 90 days, and that's not actually the fact. It's whichever is less, duration or the 90. So again, recertification, we talked about when you may need to do that because you've made significant changes to your plan, or again, at the end of the duration of the initial plan of 90 days or the actual duration, whichever is less. Delayed certification, usually when we have this issue, we actually have a form. You could just have a form that you send along with the certification that gives the reason for the delay so that you get the physician to sign off on that and the certification itself. And like I said, anything that you can send that helps to prove due diligence. So the orders, if they maybe had a doctor's visit in there and you've got a progress note that showed that the doctor was referring to therapy, telephone contact you've had, and then anything that you can log as far as requests to get those signatures made. That is always very, very helpful. So let's go into a little bit more as far as the regulations as they speak to medical necessity. So as you read through the benefit policy manual, they really go into a lot of detail here. But what you're going to see across all of the different provider types is the definition is essentially the same. Okay? They're going to allow us to see somebody to improve a patient's condition, maintain the patient's condition, or prevent slow further deterioration. So if everybody remembers a couple years ago when the JMO settlement came out, so that was a class action lawsuit that was brought by a patient against Medicare who essentially said, you know, every time I get discharged from home health, I decline. And I have a neurological condition that I really need these services, and I need the skilled services of a therapist. This is something that my family can't do for me, I can't do for myself, and that class action lawsuit was settled. Okay, and so everybody calls it the JMO settlement, but that's where we saw some of this language actually change to the point now where they added maintenance into there. Okay, so that was something very significant, and we of course got tons of phone calls from some of our administrators that they thought, well, everybody could be picked up for maintenance, and that's not the case either. It's still a case-by-case basis, but it is important to realize that with that settlement, Medicare had to go in and change some definitions that they had. These were long-standing definitions that they had in their policy manual. Okay? So again, if the service can be self-administered, you can teach an unskilled non-therapist person to do it, you need to be doing that. But there are going to be some of those cases where we may have to have a therapist involved. I'll give you a couple examples. We've had a couple people that we have maintained for some maintenance on JMO. They're very involved. We had an amputee that also had a history of a CVA that when we were doing a lot of the prosthetic training, because of the tone issue, it wasn't something that we felt safe handing over to restorative. Now, in saying that, this person may, stayed on twice a week. It was very short treatments to really focus on the gait piece of things. And a couple other patients that we've kept on, really a lot of them have been more of the neurological diagnoses or complexities or comorbidities. And again, it's something that we see them for a very brief amount of time in the clinic, and it's just to do that small piece of the therapy that the therapist still needs to be involved with. The pieces that we could hand off, we did. But that was a big and it was a significant change, okay? So what we also need to remember is that when they're looking at medical necessity, they're looking to say, are the services that you provided evidence-based? So they're really looking at, is it within the standards of current therapy practice, okay? So that's where they're really looking at some of that they consider potentially substandard or worthless care. And what they're also looking for, and we've already talked about this today, but this is the overarching principle of medical necessity, is the level of complexity and sophistication of the treatment, okay? So that's again where I say you've got to be able to brag about yourselves and what you're doing, that it's your education level and the schooling and everything, all the training that you have that really is setting apart what you're doing with that patient compared to what somebody else could do, okay? So then in the benefit policy manual, this is where you're going to see the most detail where they really define what are the documentation requirements, okay?
When we get out of the Part B world into some of the other policy manuals, they don't go into nearly as much detail. Okay, but Part B really has the minimum expectations defined, and that's the evaluation and plan of care. And like I said, typically we see that condensed into one document for most of us that are using medical record systems, but it technically could be 2 separate documents if need be. The actual certification, progress reports, and treatment notes. So when they look at the evaluation and plan of care, they said that this should document the necessity of the therapy. They want to see the diagnosis, and they want to see the results of some type of a standardized test, okay? And they actually define in the benefit policy manual the tests that they prefer, which would be NOMS, the photo, the AMPAC, or the photo. Now, a lot of people don't have access to some of these tests. You know, some of them you actually have to pay for. They're just not out there for therapists to use at their discretion. So when they say is if you're not going to use one of those, then we want to see some other type of functional standardized assessment. And luckily, you know, we have a lot of options, and it really does help us to drive the point across of where we are and are we achieving the outcomes that we're looking at. So we'll talk a little bit more about that in Part 3 about how we can really incorporate that standardized testing that we're doing with our patients and how that really can help a little bit, well, not just a little bit, it can help a lot with supporting medical necessity compared to if you're not using standardized testing. They also want to see in the evaluation documentation that supports the illness severity or the complexity of that patient. So if you've got a lot of comorbidities there, you want to get that information down there. If there are things that are going on with that patient that you think that's going to cause potentially a slower progress with that patient, make sure you're getting that information in there. Any care that they had prior to their current episode. How is this episode impacting their quality of life, and what type of social support do they have? You want to document your clinical judgments or subjective impressions of that patient when you're describing functional status or the condition that you're evaluating. And then really talking about prognosis for that patient. How well do you think they're going to do? What's the expected time frame in the plan? Re-evaluations. When do we do a re-eval, and when do we actually bill for a re-eval, okay? It's important to realize that every time you're with a patient, the wheels are turning in your head. You're constantly assessing, okay? And that constant assessment, that's just part of treatment, and Medicare expects that to be a part of treatment. So when they talk about a re-evaluation, that is when you feel the need that there's been a change with that patient, that you need to do more testing, further measurements, and likely change your plan. That's what supports a re-evaluation. It's not just that I have a progress note due, okay? That's not going to support the need for a re-eval. That's just assessing progress, okay? Progress reports. These are extremely important, okay? This is what continues to justify the medical necessity of treatment. And they have to be written by a clinician. It has to be written by the therapist who's providing the service and supervising the assistant. And it's important to remember that there's actually 2 requirements to meet the whole 10th visit progress note requirement. It's the actual writing of the actual note, but also the clinician within that 10 visit period has to have participated in treatment, okay? And so that means that they have to have provided at least 1 billable service on at least 1 day of treatment throughout that 10th visit, okay? So it can't be that the assistant's doing all the treatment, therapist comes in just to write a progress note. They have to have actively participated over those 10 visit periods. And like I said, for Mississippi, I know you guys have a 6 visit supervisory thing as well, so that's what you also want to pay attention to when you're looking at these things. Now, Medicare at least is a little bit realistic and knows that sometimes things happen. You know, what happens if the day that the therapist is there, they're planning on writing the note and everything, patient phones and cancels their appointment because they're sick, right? Therapist now is going to maybe be off for a couple days and miss the next couple appointments. So that they realize that that may happen, and they're going to allow for some delay, but they really want that progress note to be written within 7 calendar days of when it was due, okay? And you really need to make sure that when you have a delay like that, you're documenting the delay and you're documenting what the reason was for the delay and what guidance you gave to the assistant if they're going to continue to treat that person during a delay, okay? So they describe some minimum requirements of what needs to be in the progress report. You have to indicate the date of the beginning and end of the progress report period, okay, the actual date it's written, objective reports of the patient's subjective statements, objective measurements or the description and changes for each goal. And then you want your assessment. What do you think about this? If they didn't meet a goal, why? Why do you think that is? If they've met a goal and you need to upgrade something, you know, they want to see that. And that's where you're going to maybe make some of those upgrades to those short-term goals, those baby steps of what are getting us to our long-term goals, okay? And this is where you'll talk as well about any plans that you have for continued treatment, really talking about the skill that you provided in that 10-visit period, okay? That becomes extremely important. Now, as far as assistance and progress reports, they do allow assistants to write elements of a progress report that happens in between those 10th visit notes. So if any of you are doing weekly notes, maybe you're alternating an assistant note with a therapist note, but an assistant note actually does not meet all of the requirements for a Medicare progress report. So that is something that we have to remember under Part B, that it does have to be written by the therapist, okay? As far as changing goals, if an assistant is doing a weekly note, they can change a short-term goal if it's under the direction of the supervising therapist. So they would have to document that they spoke with the clinician, when they spoke with them, name and date, and that clinician's going to have to come back on the back end and verify that by co-signing or noting that when they write the progress report that they approved that short-term goal change. Treatment notes. So these are our daily notes. These are our visit notes. Every time we see the patient, this is what we're putting in writing, okay? The purpose of these notes is to create a record of all the treatments and the skilled interventions that we provide, and it's what somebody's gonna look against to look at your billing on the claim to see if it's supported, okay? So they're gonna compare your CPT codes, number of units, compared to what you did in treatment to make sure that it truly was supported. There's actually very minimal requirements of what has to be in that visit note. It's the actual date of the treatment. You're going to identify each specific intervention or modality, the total time to code treatment minutes, the total treatment time, and then your signature. So that's the minimum. But they do say you can add much more information there. You know, anything that the patient's reporting to you, adverse reactions, any communication maybe that you have with another provider, or maybe you had to call the orthotist on that patient or the prosthetist on that patient, or PT and OT are both seeing this patient and they consulted on something that they're both seeing and really discussed it. Or speech, maybe this is one of your patients that has some dementia issues and you're working with speech so that PT and OT are understanding what's the best approach I need to take when I go to work with that patient, and having speech give you some guidelines there. Any equipment that you provided, any unexpected, significant, or unusual changes. So on Medicare Part B, billing is all by CPT code, right? So we have CPT codes that we define as timed codes and our untimed codes. The timed codes are dictated, the number of units is constrained by our 8-minute rule. The untimed codes, that means it doesn't matter how much time you spent doing that, okay? I could have had somebody on unattended E-stim for 45 minutes, not that I would do that, but just as an example, and I'm gonna get 1 unit for that, okay? Those untimed codes, it does not matter. It doesn't matter if I do it on 3 body parts, okay? It's still only 1 unit. So that's just something to keep in mind there. Again, the timed codes are going to be limited based on the total time that you're with that patient based on the 8-minute rule. You want to make sure that you're recording actual minutes, okay? So there's been a lot of talk about that in the industry of seeing rounding with 0 to the nearest 0 or nearest 5. You want to make sure that you're being very specific and being actual when you're recording the actual time. And when you read through the definition of these timed codes, what you'll see is the overarching theme that almost all of them have in the definition that it's direct one-on-one care. Okay, so that's something very important to remember, that we're meeting that stipulation to meet the rule. This is just the 8-minute rule, okay? Remembering that it's, all of those time codes actually are defined as 15-minute increments, except for there's a couple that are speech therapy codes that are outliers there, that we've got some timed codes for speech that are actually based on 60 minutes, okay? But for the most part, everything is based on a 15-minute unit, and that's where we pull in that 8-minute rule that's saying you have to at least go 8 minutes into the next 15 to really dictate what those units are looking like, okay? So as an example, if I did 24 minutes of CPT code 97112, 23 minutes of 97110, that's a total of 47 minutes, okay? Well, the 8-minute rule says I can bill 3 units. So then I have to decide how am I breaking up my units. Well, I did more of 97112, so I'll do that for 2 units and 1 unit of 97110. You may have some time where it happens that you did the exact same amount or very close to the same amount on multiple CPT codes, okay? So in this example, I only spent 15 minutes with my patient, but I'm saying that I apparently did 3 different treatment interventions when I was with that patient. So I can only bill 1 unit. I need to decide which unit I'm going to choose, okay? A lot of the software systems helps you with that to decide what is probably the better option. So again, we have the untimed codes. That's the 1 unit per day per discipline, okay? These are the codes that are typically our evaluation codes, re-evaluation codes, our unattended or supervised modalities. A lot of the speech codes are actually the untimed codes. And again, doesn't matter how long you spend, okay? You're gonna get 1 unit from that. Co-treating for Part B. Now remember I said Medicare doesn't want to make life easy for you and have a nice standardized set of rules across the different provider types. So for Part B, if you were to co-treat, so we've got 2 clinicians, each from a different discipline, that are working with the same patient at the same time, and we spend 40 minutes, okay? Me and the other clinician, we have to decide how we are going to split that 40 minutes between the 2 of us. We can't both bill for that full amount of time. So maybe I take 25 and they take 15. We need to make that decision of how we're going to split that up for Part B, okay? The other thing that you want to remember from a co-treat perspective is that it has to really be based on patient need, okay? It can't be that OT and I get to the end of the day and we both have Mrs. Smith left to see, and boy, if we could just co-treat, we could both be done. Okay, it can't just be because it's logistically convenient for the therapist, okay? It really has to be driven by patient need of whether or not they need an actual co-treat. So let's move on to Medicare Part A. And we're gonna really talk about your swing beds and your SNFs here. And again, like I said, it's not nearly as detailed from a therapy perspective. There's going to be some of these overarching principles, but what you don't see them go into when you get into the benefit policy and claims processing manual on swing beds and stuff, they don't go into the detail of what is really required for documentation and everything like what they do on the Part B side of things. Most providers really kind of just keep it standard then across the board because it's just easier for everybody to remember. But we do have specific requirements that have to be met for that person to be able to be seen in a Part A PPS stay. And those are really, really important because if they don't meet these basic requirements, again, you've got an issue that their stay should not have been covered, okay? So the big one, and the one that's getting a lot of attention, is that they have to have had an inpatient hospital stay for at least 3 consecutive days. And where a lot of controversy is coming out about this is you're seeing more and more hospitals not actually admit people to an inpatient stay, and they keep them in an observation stay, okay? Those observation stay nights do not count toward the count for 3. So there's been a lot of talk out there about, that the hospital has to be very upfront. They need to alert these patients when they're in an observation stay, because what can happen is then they get admitted to the SNF, they can't be seen under a PPS stay, and we've got some issues then, okay? Because now you've got a whole talk about, have to have that uncomfortable discussion with the patient of who's paying for them to be at the facility then, right? And there's also been talk about this with some of the, as we're going to talk in the very last section today about payment reform, as they're going to some of these bundled payments. And you're looking at these stays being shorter and shorter and that type of thing, that we've got patients that probably do really qualify for a skilled stay. They're just getting hung up on this 3-day stay rule, okay? So something just to keep an eye out on. It's at least something that, you know, many people are aware of. But right now that 3 consecutive day stay is there. They have to admit to the skilled nursing facility within 30 days of discharge from the hospital, okay? So it could be that the patient really felt like, oh no, I can go home, I'll be fine. They go home, realize, you know what, this isn't quite working. Daughter, son, somebody realizes, oh, mom's a little bit more care than I thought she was gonna be. We need some more help here. If they get into the SNF within 30 days of that discharge from the hospital, they can still pick up that Part A benefit. Okay, when they come into the SNF for that PPS stay, the care that you're delivering has to be related to the condition for which they were in the hospital or a condition that came up or arose while they were in the hospital, okay? All right. So as far as looking at the SNF level of care and how they define skill, you've got multiple factors that have to be met. First of all, the patient has to require that skilled level of service, whether it's nursing or rehab. And they define that for nursing, it's 7 days a week, okay? Therapy, when they look at that skilled level of service, it's 5 days per week. So a little bit different. The skilled services have to be ordered by the physician. There has to be that admission order when they come into the facility that says, yes, they need that skilled level of care. And it's related to what they were in the hospital for. And again, there's that whole daily basis piece of it. Remember, nursing 7, therapy 5. And when they're looking at this, and there's no magic equation or anything to this, they're looking at it to say, was the SNF actually the appropriate discharge place? Is it the most economical and is it the most efficient? Is that where they truly need to be to meet the goals? And we're going to see more and more of that discussion as we talk about healthcare reform, okay? All right. So here's that definition of skilled service again. What do we see? Inherent complexity. It's all about the complexity of the care. All right. Now, this is as far as it goes to talk about really what has to be in the therapy documentation. It says services must be directly and specifically related to an active written treatment plan that's based on the initial evaluation that's performed by the therapist and it's approved by the physician, okay? So they don't call it a certification of the therapy plan, okay? You're not going to see that under Medicare A. You will hear, though, however, them talk about the certification of the Part A stay. That's when the physician certifies the entire stay. It's a separate document. That's something that's usually happening outside of therapy, okay? But if you just ever hear that term, it's that term certification for a Part A stay is very different than the way we talk about it on the Part B outpatient side of things, okay? But we do have to have our therapy plans of care approved, but they don't say how they get approved. We just take the stand that we get every initial evaluation signed by the physician, okay? That way we know we've got that signature, it's approved. And that comes in very, very handy, or, you know, this has happened to us. Maybe it doesn't happen down here in your states, but, you know, when the business office manager comes to you and goes, yeah, we thought Miss Smith was a Part A. We thought she had days left, but it turns out she doesn't, and we really need to treat her under Part B. So that way you're covered. You've got the certification on the Part B. So it just works out well. All right. The services have to be provided with the expectation that the patient's going to improve materially and that it's in a predictable period of time. Okay, now they still have in here, so the GMO settlement just wasn't for home health, it just wasn't for outpatient, it was for all types of therapy providers. So it does say in the Part A stay as well that if we need to see somebody for some maintenance care, we are allowed to do that. Now it could be that we need to see them to maybe set up a maintenance program that we could hand off, or it could be that some of that is still maintenance care that we need to be able to provide. So again, that was a very, very big change. I just always recommend, and I have a lot of the clinicians, I always say, if you think somebody needs maintenance, give me a call, let's talk through it so we can make sure that we really are, ensuring that that person really truly needs the level of care that it's gonna be a therapist. Okay, again, evidence-based practice here, accepted standards of therapy practice, all right? They also are looking at the frequency and duration being reasonable and necessary. Is that the frequency we choose, the duration we choose medically necessary? So part A, a lot of times in the electronic systems, because it would be very difficult not to have CPT codes in there just because of a different payer source. We are reporting under CPT codes, but really what gets reported onto the MDS and what goes on the claim is not our CPT codes. What really is just going is the total minutes. So, and remember we divide those out that they're individual, which means direct one-on-one care. Concurrent would mean that we are treating 2 patients at the same time, okay? And they're performing different activities. Or group, which this was a big significant change to that definition several years ago, where it had to be planned treatment for 4 patients, okay? If for some reason you planned the group for 4 people, all of a sudden Mrs. Jones doesn't feel good that day and Mrs. Jones isn't gonna participate, you can still do the group with 3, it just had to initially be planned for 4. So that's how we're reporting our minutes, and that's how it goes onto the MDS and really dictates what RUG level you get paid under, is how we're reporting those minutes for individual, concurrent, or group therapy. So the other big change that happened several years ago was the way that we could report modality time on our PPS patients, okay? This really caused a little bit of a ruckus, especially for the modality equipment vendors. They did not like this change. I know I had to meet with several of ours, and they would come in and sit down and meet with me, and they would hand me letters from their attorneys that really said that, the attorneys disagreed with the Medicare regulation change and that they thought that we could bill full time. But this is the direct quote from the RAI manual, which really dictates how we treat and bill and record everything on the MDS for our PPS patients. And it specifically says that only skilled therapy time shall be recorded on the MDS. In some instances, the time during which a resident receives a modality is partially skilled and partially unskilled, okay? Only the time that is skilled can actually be reported as therapy time on the MDS. And they go on to give an example of electrical stimulation. Instead, they go on to say that the treatment that's skilled is the time where you were looking at electrode placement, checking skin, setting up your parameters. That's what we can record under that modality for the day and what can go on the MDS. If my patient then maybe was on e-stim for another 20 minutes and it was unattended, I can't count that 20 minutes in my treatment timer on the MDS, okay? So again, this really caused a little bit of a ruckus, but this truly is how it's defined in the regulations. So completely definition for co-treatment, okay, compared to Part B. So under PPS in Part A, if 2 clinicians from different disciplines both are treating the same patient at the same time, you can both count your minutes in full, okay? Again, they want to make sure that it's clinically appropriate, it's a medically necessary co-treat. Again, it can't be that we both have Mrs. Smith, at the end of the day, and we both need to see her. But complete opposite of how we have to report co-treat on Part B, okay? And this is something they didn't really, Medicare wasn't really out there going, hey, look at this change about co-treat for Part A. They really kind of kept this kind of quiet, and then you read through it and you were like, now wait a second, what do you mean we can count full minutes again? So again, totally different between Part A and Part B. Okay, so national coverage determinations. These are also in a manual, and that's everything that we've talked about so far. I want to make that point because earlier when the attorneys were speaking, they made a very good point when they talked about intent, or they talked about people being able to say, oh, I didn't know, okay? Every manual that I'm discussing here, so the benefit policy manual, claims processing manual, there's a national coverage determination manual, they are all out on the CMS website. So they're never gonna accept when somebody would say, oh, I didn't know. because you have this, everyone has this available to them to go out and should know the information, okay? So national coverage determinations are actually set by CMS. And this is, I think there's 4 different chapters to this manual, and there are several that really do relate to therapy, and they basically are letting us know when is it going to be covered and when is it not going to be covered. One of which is biofeedback therapy for the treatment of urinary incontinence. And basically they say it is covered, okay? But the patient has to be cognitively intact, and they have to have documentation that they've failed a documented trial of pelvic muscle exercise training. If they have that documentation that they have failed that PME training, then we can implement biofeedback with that patient. Okay. Electrical stimulation or electromagnetic therapy or diathermy for wounds. This is a very, very specific NCD. It has a lot of pieces to it, okay? They first of all define what type of wound can we treat. It has to be a chronic stage 3 or stage 4. It has to be a pressure ulcer, arterial ulcer, diabetic ulcer, or venous stasis ulcer, okay? And it has to have shown that it has been failed 30 days of conservative treatment, okay? So we have to have shown no signs of improvement over 30 days. It has to be that stage 3 or 4. Then we can institute some e-stim or some diathermy for that wound, okay? If we are seeing somebody for this, the physician does have to see that person on a monthly basis to reassess them, okay? All right, infrared. Essentially what they say about infrared is that it is not covered. This is also going to be related to anodyne. So anybody that's had a vendor come out and want to have them use anodyne, it's not covered for Medicare. E-stim for Bell's palsy is not a covered service under Medicare. And then they do give some specifics about neuromuscular e-stim. It can be used to treat muscle atrophy, but the nerve supply has to be intact. And then they say that you can also use it for patients with spinal cord injury that you're working on gait training. It can be used as long as it's the gait training piece of things and it's not just to prevent the muscle atrophy piece. So those are national coverage determinations, okay? So Medicare really dictates that overall. No one can really say, oh, we don't agree with that national coverage determination. We're gonna, write something different in the local coverage determination. Those national coverage determinations trump the local, okay? The local coverage determinations are written by your Medicare administrative contractor, okay? And so when I got with Mark and I was putting this together, Novitas is who you guys have, and so we're gonna just go through some of the points of what they have in their local coverage determination. They have separate local coverage determinations. There's one for physical and occupational therapy, and then we have separate LCDs for speech therapy. So let's go over the PT and OT one first. Basically, this first slide, it's a very big paragraph that basically comes down to they want to make sure that the patient is receiving active treatment, okay? So what they're saying there is we don't want to just see a lot of modality use on a patient. There may be times where you have somebody with maybe a very acute level of pain or something that it's appropriate to start with a higher level of modality, but we want to see that get weaned down and truly it be more active therapeutic procedure with that patient. So long paragraph to say something that simple. They give detail about what they're not going to cover. So remember, the MACs can do that. They can go beyond what Medicare has in their national coverages and talk about what they're not going to cover. And very specific here in Novitas's LCD, you can see they mention the infrared. They also will not cover iontophoresis or phonophoresis. And then they talk about the fact that they're not going to cover therapy when it's more for things that they think somebody else could be doing. So they don't want to see therapy being done for general good and welfare of patients. They don't want therapy that's repetitive exercise to maintain gait, maintain strength and endurance, or assisted walking. Range of motion and passive exercise would not be something that's covered. And again, they talk about maintenance therapy. So what we need to remember is that if we are doing any type of maintenance under the GMO settlement, it truly has to be that it requires the skill level of the therapist to provide that level of treatment. They then talk a little bit in detail about frequency and duration, that they want to make sure that what you're choosing for your frequency and duration is medically necessary. They said that treatment times per session, again, this is more on the Part B side of things, typically are not going to exceed 45 to 60 minutes. But it's okay if you do. They just said you're going to have to document why that person's a little bit slower to respond or why they're needing that extra care, okay? And that generally only one heating modality per day is reasonable and necessary. So they go into a little bit of detail actually on multiple CPT codes, and we're going to go into a lot more detail here, so I'm just going to hit the highlights. Therapeutic exercise 97110. The purpose of that code is to restore strength, endurance, range of motion, or flexibility. So obviously in my evaluation, if I'm going to use CPT code 97110, I have to show an objective loss of range of motion, strength, flexibility, or endurance. And really this is the key area where they're looking for why is it skilled? What did you do with that patient that really supported that this needed to be the skills of a therapist? They want to see that you start to transition that patient to a home exercise program or restorative nursing. And if it is an endurance issue, that we are doing that skilled monitoring of that cardiopulmonary response, and that those parameters are considered when we are setting up the program. Neuromuscular reeducation, this is actually a CPT code that I feel tends to get underbilled when I typically look, because this is really something we do a ton of, okay? This is when we're working on restoring balance, coordination, kinesthetic sense, posture, proprioception. So something that we really typically spend quite a bit of time with patients on. And we just want to make sure that our documentation is supporting that there is an objective loss. And again, the assistance needed, and we're going to get more into that in Part 3 here. Gait training. This code has come under a lot of scrutiny, and so they give some examples there. Again, it's direct one-on-one care. They're looking for objective measures. Why does the patient need assistance with gait? Is there some balance issues, distance, amount of assistive device? Really, what is the gait training technique that you're using? It's not that you just put a gait belt on them and took them for a walk down the hallway. Okay, and that's where we'll talk as we get into Part 3, how we can do a better job of really letting the people that are looking at our documentation understand what's different about that and why it isn't something that somebody else could do. They are very specific in the LCD and say that we should not be doing gait training if walking ability is not expected to improve. That makes sense. Repetitive walk strengthening to increase endurance or distance is not covered, and they caution us if the person's only deviation is an antalgia. Massage therapy. Not something that we see get billed a lot. Most of the time we're going under more CPT code 97140 for manual therapy related to that, but they do speak about it a little bit. But under 97140, this is anything that we're doing hands-on with that patient that's dealing with restricted motion of soft tissue, articular structures, if it's neural issues, if we've got neural tension issues with that patient. So this to me really is always very, very skilled. We just need to make sure that we're portraying it. The therapeutic activity, this is function. This is all about functional activity, and it's function on the side of the patient. So I always tell people, think ING. Whatever the patient did was action. It was activity. So they were pushing, they were pulling, they were lunging, they were squatting, they were lifting, they were carrying. So it's very much active on the part of the patient. And then self-care home management. So the one thing I want to point out about this one is sometimes what I'll see therapists do is they make the mistake of thinking all home instruction goes under this code, and that's not the fact. When you are billing for skilled instruction, home exercise program instruction, you actually want to bill it under the CPT code that it best meets up with. So if I'm instructing a person in a home exercise program that's for strength and range of motion, that education time is going to go under 97110. If I was doing ADL, compensatory technique instruction, I would put it under this 97535. If I was teaching them a balance program for home, I would put that under 97112. So not all home instruction goes under this code. Okay, wheelchair management, they do limit some of that. They say up to 4 visits in 1 month. That's the main thing there. And then orthotic training, really looking at, is it orthotic training that needs the skills of a therapist. So they caution on things like some of the off-the-shelf things, or carrots, towel roll type thing that really don't necessarily need the skills of a therapist, something that we could be getting nursing involved with on some of those initial interventions. And if those obviously fail and we need to be doing something a little bit differently, that we could get more involved. And just remember that they are very picky about the repetitive range of motion, passive range of motion. So I usually tell therapists when I watch them and they want to just say that something's range of motion, typically they're doing a little bit more than that. Typically there's some manual therapy involved. They might be mobilizing joints. They're doing some soft tissue work. They may be doing more of a PNF, contract, relax type treatment. So you really, again, just want to take credit for those techniques and not just write that you did something as simple as range of motion. Okay, because typically, like I said, when I watch, it's something very different. We've got prosthetic training that's pretty self-explanatory. The thing to remember is that if you're actually billing, if it's gait training in the prosthesis, you bill it as gait training. That's not prosthetic training. The prosthetic training really is more the skincare, modification of fit, really getting that limb prepped and ready. Okay, and then 97762 is the checkout for orthotic or prosthetic. So this would be somebody that you've given a prosthesis to or you've given an orthotic to. The fit was established, they're doing good, and now you're doing a follow-up visit related to that, maybe checking skin integrity, checking for pain, may have to modify that orthotic a little bit if there is any kind of an issue. So speech therapy, there's just a few things that they're really particular about speech. One thing that I do want to make sure that everybody is aware that in the speech therapy local coverage determination, swallow's pretty easy because the swallow codes are very simple. It's going to be in one of the R13 codes for swallow under ICD-10, but they're very specific for cognition and language patients about which diagnoses are going to be covered and which are not if you're a speech therapist, okay? So you really want to make sure that you know this LCD. I always tell speech therapists, and we see this this is not unique to Novitas, it's pretty much every single one of the MACs. When it relates to cognition and language, they have a list of diagnosis codes at the end that are the codes that are going to be covered. And so I always tell speech, make sure you know your LCD and make sure you know it well, because if you don't code one of those codes, your claim's going to deny. Okay, so it's very important, and for the most part they're pretty comprehensive lists. There are some unique things about Novitas in that when you look at the list of codes at the end of the LCD, there are some that have an asterisk by them, and those are very important because what that means is if you've got that code, that can't be the only code on your claim. It's going to say you also have to do a secondary of one of the non-asterisk codes. So very important that speech therapists are aware of that list of codes. Like I said, otherwise it ends up being a denial, and you hate to have that because you do want to just make sure that you're coding it correctly based on the LCD. So they go into a little detail about CPT code 96105, which is your assessment of aphasia. And they basically say, and this is one of your 1 hour codes, so we've got some untimed codes that are 1 hours. This is one for speech. They basically say that a comprehensive aphasia assessment is generally only covered one time. Okay, so that's something to remember. They understand that you may do some more testing as part of some of your reassessment and assessment with that patient, but it truly, that assessment, just like how we defined re-evals for PT and OT, that's just continuing assessment. It's not truly going to meet the definition of this comprehensive assessment every single time. Then we have CPT code 96125, which is the cognitive performance testing. And again, this is another 1 hour code, okay? And what's unique about these 1 hour codes is that it actually also involves the time that it takes you to interpret your test and prepare your report. So that's really unique in the definition of these codes compared to any of the other codes. And for the cognitive testing, it can be a norm referenced or a criterion reference test that you're using to meet the needs of the CPT code. Okay. CPT 92507, that's our treatment and intervention for things
related to speech, articulation, fluency in voice, language skills, the cognitive aspect of communication. So that's really important because we get a lot of questions about when you're treating cognition, is it 92507 or is it 97532, okay? 97532, we're seeing more and more of the payers, whether it's private or the local coverage determinations for Medicare, they're getting much more restrictive on when you can bill 97532. And what they are typically saying now, 97532 is for those type of acquired cognitive impairments that are related to a head trauma, acute CVA, or other neurological type diseases. This code really isn't meant to be used more with your dementia type situation, okay? Typically that's a combination of a cognition language loss due to the progression of dementia, so they really recommend that that's usually 92507 used on the dementia patients. See here. Okay, good. We're a little bit ahead of schedule, which is what I wanted to be because I wanted to get to this third module because I knew we were going to need a little bit more time. So we're going to talk about putting it all together. So if you remember when I opened up this morning, what I said was at the heart of the matter, we've talked a lot about the regulatory side of things, the scrutiny side of things, but what we always need to remember is that we're taking care of a person. Okay? There's a person on the end of that treatment, on the end of that evaluation. There's a person that we're having to apply all of this regulatory information about and still be able to take good care of that patient and provide quality care to that patient. Okay? So when you think about putting it all together, it's about you and it's about the patient. Okay? It's how the two of you are making this happen. All right? And you're both just as important to this process. All right? So when we're thinking about putting it all together and what that all entails, we want to think about, first of all, is the person in the right setting? Is outpatient the right setting? Is SNF the right setting? Is home health the right setting? Is it the right setting at the right time? And this is going to become really apparent as we talk about payment reform and as they're really starting to look at this type of things. And in the setting that we have that patient, what is the appropriate intensity? Okay? We're going to get into some detail there. There's no magic formula to setting that, and we'll talk about really things to think about when you're thinking about what's the appropriate intensity, but there really is no magic formula. And again, what's the appropriate duration? How are we knowing that this person is ready to go to the next lesser care level? You know, if I've got them in an inpatient rehab unit, you know, do I need to downgrade them to a SNF or home health or outpatient? If they're in a SNF, are they ready to go to home health or outpatient? How do I know that they're ready to make that transition of care and that it's going to be a smooth and it's going to be a safe transition of care for that person, okay? So again, how do we support all of that information? And then how do we know if we were successful with the patient? How do we know if we did a good job? How do we know if the quality of care was there? So when you think about putting it all together, it really is sort of a three-step process. It's the intake, it's the evaluation of that patient, then we have the intervention, and then we have the outcome, okay? So in all of that, we're documenting. And I just like to remind people of why we document, because again, we already acknowledged earlier today, right, this is not the reason why you guys went into therapy. It's not because you wanted to document, but it really is important. It's really what's fostering the continuity of care as a communication tool between providers. So you're thinking about it as far as maybe I am coming in tomorrow to cover a patient that you saw today, okay? I need to be able to look at your documentation and get enough information so that I can pick up that treatment, okay? I know where the next step is, what direction you were heading with that person. So it's not really a worthless visit when I come in to see that person. Again, we have to support our clinical decision making. We have to make sure that we're assessing and managing the risk that's involved with the patient care, that we're doing a good job of documenting the skilled services, we're supporting the billing that we had on the claim, remembering that our documentation can be evidence in litigation, and not only evidence, but if you're being deposed, it's what you're referring back to when you're going through a deposition. And remember, those depositions, they don't happen 2 weeks after you treated this person. That process doesn't happen that fast. This can be years later. So you need to have enough in that documentation that when you go back to look at it to refresh your memory before you're sitting in a deposition, that you have enough information to be able to answer the questions that the attorney is going to ask.
It helps to know if we were in compliance with regulations, and again, we've got that whole quality measure component. So let's start with the intake, and I want to get you guys a little bit awake after lunch because I know it's hard to sit after lunch and listen. Okay, so in your binder, you should have a list of case studies that describe several different patients. Let's see if I can find it. So it looks like it's in the section that was right before the attorneys section. Do you guys see that? Everybody find it? Okay. So what I want you to do is I want you to just pick, each of you pick one of the case studies that looks like it's a patient that you may work with at some point. And I tried to write these, you know, it could be that they're in the SNF, in the swing bed. It could be that you're seeing them actually in home health, okay? Or that you're seeing them for outpatient therapy. I want you to look at one of the scenarios and I want you to think about what are at least 3 things I would evaluate on this patient. What are 3 things I would want to look at, okay? Think about that and write it down. And as you're writing down the 3 things that you would want to evaluate, tell me how you're going to do it. So for example, if it was strength, maybe I'm going to do a manual muscle test grade, okay? Good old standard Kendall manual muscle test, okay? The Bible, right? Of therapy. But is there a way I could even do a better job with that? Could I use a standardized test for it instead? Okay, think about that option for the 3 things that you chose. You guys are so quiet. You could talk too. If the person next to you looks like they're falling asleep, make them do a 30-second chair stand. Wake them up. All right, anybody want to share the 3 things that they would have evaluated? Anybody? Raise your hand so I know where that voice is coming from. Go ahead. Okay, perfect. Any standardized test you were going to do with her? Okay. Okay. Anybody else want to share? It's easy. Mark? Mm-hmm. Perfect. Okay. Anybody else? I've got 2 PTs. Where's the OTs in the room? There's no OTs that work for MidSouth. Come on, somebody from OT. Nobody from OT. Oh, you guys. Speech, anybody want to share? PTs are going to get the prize today, I guess. Okay, so let's talk through it a little bit. We have a lot of different things that we could really look at on different patients. And so I want to talk through that a little bit because it's so important. That evaluation really has to paint that picture, okay? So when you're thinking about it, from a range of motion perspective, not a lot more that we can do is our typical goniometric measurement, right? That's what we're typically going to do. Strength, we can do the manual muscle test. What are some standardized tests we have there? We've got some really good options, and I already mentioned one. Okay, so from a PT perspective, if you're looking at lower extremity strength, you can do a chair stand test. That's what that test is for. So you can do the 5 times sit to stand or the 30-second chair stand test, okay? Lots of times your patient tends to manual muscle test pretty decent, but then you go and ask them to do that test, and it doesn't look so pretty, okay? But it's a very functional strength test. And I don't know if anybody saw, there was a research article that came out several months ago that it was interesting because they did the study on twins, and it was over a extended period of time, and what they found is that the twins that maintain, out of the two twins pairings, the one that maintained lower extremity leg power had a slower onset of dementia. So it's just sort of interesting. So the chair stand test, I think, really can tell us a lot and really guide us sometimes further into treatment than we probably thought we really needed to go. But it's a great test, and I think sometimes we're not always taking that person to where we completely could be if we would have done the standardized test. From an OT perspective, you have the arm curl test. It's a much more functional way to assess strength. So that's another option. And then we, of course, have the dynamometers and all the grip and pin strengths that we can do versus just doing a simple manual muscle test. Okay. Coordination. Was anybody going to look at coordination on any of the patients? Okay, so we've got lots of standardized testing that we can do there. We've got, the non-standardized tests, which is, the rapid alternating movements, finger, nose, finger, doing heel, shin, some of those things. But if we really want to make it standardized, we can look at 9-hole peg, we can look at the box and blocks, we can look at the hand manipulation, Purdue pegboard, things that are going to really give some objective measures, and there's norms related to these tests so that when we go to write goals, we can use those norms and really show more of that standardized way of where our patient is. Activity tolerance. Did anybody work on activity tolerance with any of the patients or want to evaluate that on any of the cardiopulmonary people? Okay. What's a standardized test we could do on a cardiopulmonary patient? Cardiopulmonary, somebody that's got endurance issues. Two-minute walk, 6-minute walk, very simple, okay? Gives us a lot more information than simply saying that we need to increase some distance. We're gonna, again, have some values that we can assign there, okay? Sitting balance. Was anybody gonna look at sitting balance on anybody? Okay, time sitting balance. We've got a couple other standardized tests. What else you got? Functional reach and sitting. I heard that from somewhere over here. I don't know who said it, but yep, perfect. One more, and this is one I've been doing this for 20 years, and I just learned it at a continuing education that I went to about 1.5 years, 2 years ago. And it's a test that I really love, and I really, really love it for occupational therapy. It's called the Function in Sitting Test. Function in Sitting Test. It looks at 14 different things that you have the patient do while they're in sitting, and you're scoring each one of them. And the movement patterns that you ask them to do completely mimic a seated ADL session. Love it, absolutely love it. So if you're not familiar with the test, I really recommend that you look it up or email me after the course, and I've got a copy that I'll send to you because it's really a great test. And it just gives a lot more information than saying fair sitting, fair plus sitting, good sitting. Now I've got a score assigned to it, okay? Standing balance. I know we had some balance work in the back. And the Berg was mentioned. Anything else you can think of that we could do as a standardized test for balance? Modified sit-sib, perfect. Tonetti, yep. We said the Berg. Anything else? Tug, one leg stand. That's quick and dirty and easy, right? All right. Bed mobility, we heard that somebody was going to look at bed mobility. Great. Transfers. Not a lot of standardized testing there. There are some standardized tests like elderly mobility and some of those tests that incorporate several different things into it, that those are pieces of it. So sometimes that becomes very nice as well. All right, gait. What can we look at with gait that really helps to standardize it? One somebody mentioned in balance that we can do for both balance and gait. So we can do the tug, we can do the Tinetti, functional gait assessment, dynamic gait index, both really great tests. If you've got a patient that's having trouble with obstacle negotiation and turns, what's a good test? Four-square step test, okay? Nice, quick, easy test, and really focuses in on negotiating the obstacle and being able to turn, okay? One more thing that we can look at in gait to help give it some additional objective information, and they're calling it the sixth vital sign. Really helps us to understand where is the appropriate discharge setting, and are they going to be safe? Gait speed, 10-meter walk, okay? Getting that gait speed on your patient, because they need to be doing 0.8 meters per second to be safe in the community, okay? All right, OT, what can you be doing for when you're assessing ADLs to give it a little bit more of an objective information and give it a number? Functional, Barthel, modified Barthel. We've got the CATs. For IADLs, you could do the Lawton, okay? OT doesn't have quite as many tests as what PT has. PT has over 400 standardized tests. It gets a little crazy. So I'm just giving you the top ones that I see used most often, or I think that are typically the ones that we're gonna have better norms for to be able to do some comparisons. Okay, speech therapy. Things you can do that are more standardized for cognition and language. I hear something over there. Yep, absolutely. So doing the RIPM, we've got the RIPA-G, right? So we've got that. We've got the CLACs. I have to talk about the slums because I'm a St. Louis University grad, so they would be really upset if I didn't talk about that since it came out of my university. Hidden objects, doing trail making, the three-word shapes. I mean, there's a lot that's out there, that's really out there for speech. And that's why they always have all those really pretty percentages and scores and successful trials out of total trials. And it's always much more objective than what we probably do in PT and OT. So speech has a lot of options, okay? So they've got the dementia scales as well. And then when you get into more of your pain type patients or your more orthopedic type patients, we really have a lot of body part specific tests that we can be adding in to add some extra information. So if you were doing a vestibular patient, there's a great dizziness handicap that you can be doing and reassessing at progress notes. It's not necessarily as much of a test as it's a questionnaire that the patient fills out. And it really lets you know how they're feeling and how they're feeling that improvement is. But it really lends a lot to really support your documentation of where you're at with that person. For cervical, we've got the neck disability index, or the Oswestry. Nice thing to repeat at progress note times with those patients. For lower body, lumbar, we've got the Oswestry as well. For hip and knee, definitely something you want to be looking into here on what you're doing for those patients and what you can potentially add in as some type of a questionnaire or test, because we're going to see that as we get into the bundled payment piece of things. But that's going to be a requirement, well, not actually, it's sort of like an optional requirement under the quality piece of using the who's or the coos. So something that if you could be also mimicking that in your therapy sessions, that would be something that really is great. Lower extremity functional scale is a bit higher level test. And then for upper extremity, the disabilities of the arm, shoulder, hand is a really nice questionnaire to do for anybody that you've got upper extremity pain issues that you're treating that person for. We've got the Wolfgang for rotator cuff, and also a really nice rheumatoid hand function test if that's something that you'd ever be addressing. But when you can add those pieces into your evaluation and then get that into your goals, it really does make a huge difference. Okay, so now I want you to think about the patient, all right, that you were going to work with here. And I want you to start thinking as I'm talking through this, because we're probably going to end up going to maybe break before we get to this portion, but you've got to write goals for your patient, okay? So we had our evaluation findings. We know where our deficits were compared to prior level of function. That's what dictates what type of goal I'm going to write. If I've got a decline from prior level, and it's something I want to work on, I need to write a goal for it, okay? And it really helps to show when I'm writing that goal list, where is the focus of my treatment? What's the direction I want to head with this person? And then that's what I'm reporting on from progress report to progress report, so I can decide, am I making progress or not? It's very important that when we write our goals that they're patient-centered, that they're objective, and that they're measurable, okay? Again, they also need to support medical necessity of my plan of care. And you want to make sure that you're addressing all function and impairments that you want to address in treatment. So I will give you a little quick story about this. It won't take too long, but we had a review that happened recently. It was an external review, and PT got denied. So reason PT got denied is the PT assistant put in their documentation on several visits that they worked on bed mobility and transfer training. Well, the evaluation said that the patient was independent in bed mobility and independent in transfers, and there were no goals on the plan of care. So rightfully got denied. It really should have been denied. Now, if you dug into the chart a little bit more, looked at nursing documentation, really dug into therapy documentation, what you found is that after the initial evaluation with this patient, he started to have some significant lower extremity pain. And so he actually did decline in bed mobility and transfers compared to what the eval showed. But nobody took the time to adjust the plan of care. Okay? So he really did need some treatment around that, but because they really missed the boat on that piece of things, it ended up being denied. Okay, so remember I said we want patient-focused, we want objective measurable, and you really want to try and keep your goals as functional as possible, okay? So looking at these goals, do you think I liked them? First goal is patient will increase right hip flexion range of motion to 90 degrees to increase independence with gait. Did I like the goal? Is it patient-centered? Right, it says patient will, it's all about the patient. Is it objective and measurable? The 90 degrees of range of motion is, right? That's objective, it's measurable. We can take that measurement every time we go to do the note. Do I like that they tied 90 degrees of hip flexion range of motion to gait? Yeah, unless we're high stepping. I don't need 90 degrees of hip range of motion to ambulate, okay? So this is one I sent back to the therapist and said, you know, I just need you need to change up your functional reason for why you're doing this. And he goes, well, Shawn, I thought that the whole point of us treating patients is to optimize their wellness. I said, I'm not saying you can't work to get this guy to 90 degrees of hip flexion, but it needs to be related to something you need 90 degrees of hip flexion for. So it could be moving from sit to stand, where I need at least 90 degrees, if not more, to be able to weight shift forward. But it's not gait, okay? Increase lower extremity strength from 3+ to 4 out of 5 in bilateral lower extremities. Did I like that goal? I didn't. Why? They didn't give me a reason why. What's going to be my functional outcome here, right? Okay. Patient will increase gait from 50 feet to 150 feet with min assist with a cane. Do I like it? It's fair. What could make it better? Destination would help. What else helps to support why they need me as a therapist? Gait pattern. What's the gait pattern that I'm addressing with skilled gait training?
okay? Distance alone does not cut it for Medicare, okay? All right, so I want you to, let's see how we're doing on time. Okay, we've got 2 minutes. I'm gonna let you guys break, but while you're breaking, I want you to think about, on your case study that you have, 3 goals you would write for that patient, okay?